Everyone, and welcome back to a Vital Nursing 101 video. Today we are talking about a medication every nursing student needs to understand: Naloxone, also known by the brand name Narcan. Naloxone is one of those medications that can save a life very quickly when it is used at the right time. You will hear about Naloxone in the hospital, in emergency departments, in post-op care, in community health, in mental health, in substance use treatment, and even in public spaces, because Naloxone nasal spray is available over the counter. But here is the key nursing point: Naloxone is not just the medication for overdose. It is specifically an opioid reversal medication. That means it is used when a person has too much opioid effect in the body, especially when breathing is too slow or stopped. In this video, we are going to break down Naloxone step by step. We will talk about what Naloxone is, why it is used, how it works, signs of opioid overdose, routes of administration, side effects, black box warnings or major warnings, nursing responsibilities, lab monitoring, patient teaching, and what findings should be reported to the provider. And throughout the video, I will add pop test questions to help you think like a nurse. Let's start with the basics. Naloxone is an opioid antagonist. That word antagonist means blocker. So Naloxone blocks opioids. A simple way to remember this is, Naloxone knocks opioids off. Naloxone knocks opioids off the opioid receptors. Opioids include medications and substances like morphine, hydromorphone, oxycodone, hydrocodone, fentanyl, heroin, codeine, and methadone. These substances attach to opioid receptors in the brain and body. When opioids attach to those receptors, they can reduce pain, but they can also slow breathing, cause sedation, lower blood pressure, and lead to overdose. Naloxone comes in and blocks those opioid receptors. When naloxone blocks the receptors, it can reverse opioid effects, especially dangerous breathing problems. The most important reason naloxone is given is respiratory depression. Respiratory depression means the person's breathing is too slow, too shallow, or not effective enough to support oxygenation. In an opioid overdose, breathing can slow down or stop. Naloxone can help restore breathing by reversing the opioid effect. Pop test question: Naloxone is classified as what type of medication? A. Opioid agonist. B. Opioid antagonist. C. Antibiotic. D. Anticoagulant. The correct answer is B. Naloxone is an opioid antagonist, which means it blocks opioid effects. Now let's talk about why naloxone is used. Naloxone is used for known or suspected opioid overdose. Known means we know the person took an opioid. Suspected means we may not know for sure, but the signs point toward opioid overdose. For example, a patient after surgery receives IV hydromorphone for pain. Later, the nurse finds the patient very difficult to arouse, breathing 6 times per minute, and oxygen saturation is dropping. That is a possible opioid emergency. Another example: a person is found unresponsive with slow breathing and pinpoint pupils after using an unknown substance. That is a suspected opioid overdose. Another example: a child accidentally takes an opioid medication from a family member's bottle and becomes very sleepy with slow breathing. That is an emergency. Naloxone can be used in adults, children, and infants when opioid overdose is suspected, but dosing and route depend on age, situation, setting, and product instructions. In the hospital, naloxone may be given IV because it works quickly and can be titrated carefully. In the community, naloxone nasal spray is common because it is simple to use and does not require needles. The most common brand name people know is Narcan. Memory tip: Narcan wakes breathing. That does not mean the person will always wake up fully right away, but the life-saving goal is breathing. The goal of naloxone is not to punish the person or instantly remove every opioid effect. The goal is to restore adequate breathing. Pop test question: what is the priority reason to give naloxone in an opioid overdose? A. To lower blood sugar. B. To reverse dangerous respiratory depression. C. To treat infection. D. To reduce cholesterol. The correct answer is B. Naloxone is used to reverse opioid-induced respiratory depression. Now let's talk about how opioids cause overdose symptoms. Opioids attach to opioid receptors in the brain and spinal cord. This can reduce pain, but opioids can also affect the brainstem, which helps control breathing. When there is too much opioid effect, the brain does not respond normally to carbon dioxide levels. The person breathes more slowly. They may breathe very shallowly. They may stop breathing. This is why opioid overdose is so dangerous. The person may not get enough oxygen to the brain and organs. If not treated quickly, this can lead to brain injury, cardiac arrest, or death. Common signs of opioid overdose include slow breathing, shallow breathing, no breathing, extreme sleepiness, inability to wake up, limp body, blue or gray lips or fingertips, snoring or gurgling sounds, slow heart rate, low blood pressure, and pinpoint pupils. Pinpoint pupils are very tiny pupils. But remember, not every person will have all signs. Do not wait for pinpoint pupils if the person is not breathing. Breathing is the priority. A helpful memory tip is, opioid overdose makes the body slow. Slow breathing, slow heart rate, slow response, extreme sleepiness. Pop test question. Which finding is most concerning for opioid overdose? A. Respiratory rate of 6 breaths per minute and difficult to arouse. B. Mild headache with normal breathing. C. Increased appetite. D. Dry skin only. The correct answer is A. Very slow breathing and decreased responsiveness are emergency warning signs of opioid overdose. Now let's talk about how naloxone works. Naloxone has a stronger attraction to opioid receptors than many opioids do, so it competes for the receptor and can push the opioid off. Think of the opioid receptor like a parking spot. The opioid is parked in the spot, causing opioid effects. Naloxone comes in and takes that parking spot away. Once naloxone is on the receptor, the opioid cannot keep causing the same effect. That is why breathing can improve. But here's the important part. Naloxone is temporary. Naloxone may wear off before the opioid wears off. That means the person can become sedated again or stop breathing again after naloxone wears off. This is sometimes called resedation or recurrent respiratory depression. Some people use the word re-narcotization. So after naloxone is given, the person still needs emergency evaluation and monitoring. This is why patient teaching says, give naloxone, call emergency services, and stay with the person if safe. Do not give naloxone and walk away. Do not assume the person is fine because they woke up. The overdose can return. Pop test question. Why should a patient be monitored after naloxone works? A. Naloxone can wear off before the opioid wears off. B. Naloxone permanently removes all opioids from the body. C. Naloxone cures opioid use disorder instantly. D. Naloxone treats bacterial infections. The correct answer is A. Naloxone's effects may not last as long as the opioid, so respiratory depression can return. Now let's talk about routes of administration. Naloxone can be given several ways. It can be given intranasally, which means sprayed into the nose. It can be given intramuscularly, which means injected into a muscle. It can be given subcutaneously, which means injected under the skin. It can be given intravenously, which means into a vein. In hospitals, IV naloxone is often used because it works quickly and can be carefully titrated. Titrated means adjusted in small amounts based on the patient's response. For example, in a hospitalized patient who received too much opioid pain medication, the goal may be to improve breathing while not completely removing all pain control at once. In community settings, nasal spray is common. Narcan nasal spray is designed to be easy to use. You do not need to assemble anything. You place the tip into one nostril and press the plunger. The medication sprays into the nose. The person does not need to inhale for it to work. This is very important. Even if the person is unconscious and not breathing well, nasal naloxone can still be administered. If there is no response after a few minutes, or if the person responds but then becomes unresponsive again, another dose may be needed according to product directions and emergency guidance. Pop test question. For naloxone nasal spray, does the person need to inhale for the medication to work? A. Yes, they must take a deep breath. B. No, the spray can still be absorbed through the nasal tissue. C. Yes, they must drink water first. D. No, but it only works if swallowed. The correct answer is B. Naloxone nasal spray can be absorbed through the nasal tissue even if the person is not able to inhale deeply. Now let's talk about timing. Naloxone usually works quickly, but response time can vary based on the route, dose, opioid involved, and the person's condition. IV naloxone can work very quickly. Nasal and IM forms may take a few minutes. If the opioid involved is very strong or long-acting, more than one dose may be needed. Fentanyl and other potent synthetic opioids can sometimes require repeated dosing. Long-acting opioids like extended-release oxycodone or methadone can outlast naloxone. That is why monitoring is so important. A person may wake up and breathe better, then become sleepy again. So the nursing mindset is, naloxone is emergency reversal, not complete treatment. The complete response includes airway support, breathing support, emergency help, assessment, monitoring, and follow-up care. Pop test question. A person receives naloxone and starts breathing better. What is the next best step? A. Leave them alone because they are cured. B. Continue monitoring and make sure emergency help is involved. C. Give them alcohol to calm them down. D. Tell them to go back to sleep without monitoring. The correct answer is B. Naloxone can wear off, so the person needs continued monitoring and emergency evaluation. Now let's talk about side effects. Naloxone itself does not cause a high and has no abuse potential. If someone has not taken opioids, naloxone usually has little to no effect. But if someone has opioids in their system, naloxone can suddenly reverse opioid effects. That can cause withdrawal symptoms in people who are physically dependent on opioids. Withdrawal can feel very uncomfortable. Symptoms may include agitation, anxiety, restlessness, sweating, nausea, vomiting, diarrhea, abdominal cramps, body aches, runny nose, yawning, goosebumps, fast heart rate, increased blood pressure, and tremors. The patient may wake up confused, angry, scared, or in pain. This can be challenging in a clinical setting. But remember, the priority is breathing. Withdrawal is uncomfortable, but respiratory arrest is life-threatening. In newborns exposed to opioids, naloxone may also cause withdrawal, so use is based on provider orders and clinical guidelines. Naloxone may also cause rapid return of pain in patients who were taking opioids for pain control. For example, a post-op patient who receives naloxone after opioid-induced respiratory depression may suddenly have severe pain again. The nurse should still prioritize airway and breathing, then work with the provider to manage pain safely. Pop test question. A patient wakes up after naloxone feeling anxious, sweating, nauseated, and angry. What may be happening? A. Opioid withdrawal. B. Low calcium. C. Antibiotic resistance. D. Hypoglycemia. Only. The correct answer is A. Naloxone can trigger withdrawal symptoms in people who are physically dependent on opioids. Now let's discuss black box warnings and major warnings. Naloxone does not have the same kind of addiction warning as opioids because naloxone is not addictive and is not a controlled substance. However, it has major warnings that nursing students must know. First, naloxone is not a substitute for emergency medical care. It is emergency treatment, but the person still needs medical evaluation because opioid effects can return. Second, repeated doses may be needed. If the person does not respond, or if breathing slows again, another dose may be required according to the product instructions and emergency protocol. Third, naloxone can cause sudden opioid withdrawal. This can cause agitation, vomiting, sweating, fast heart rate, blood pressure changes, and severe discomfort. Fourth, after naloxone works, the patient may become combative or confused. This may happen because they wake up suddenly, feel withdrawal, feel pain, or do not understand what happened. Safety matters. Protect the patient, protect staff, and keep the environment safe. Fifth, vomiting can occur. If the patient is very sedated or has a decreased level of consciousness, vomiting increases aspiration risk. Aspiration means stomach contents go into the airway or lungs, so airway positioning matters. Pop test question. Which statement about naloxone is correct? A. It replaces the need to call emergency services. B. It can reverse opioid overdose, but the person still needs monitoring and emergency care. C. It is used to treat all types of drug overdose. D. It causes an opioid high. The correct answer is B. Naloxone can reverse opioid effects, but continued monitoring and emergency care are still needed. Now let's talk about nursing responsibilities before giving naloxone. In an emergency, you do not delay naloxone when opioid overdose is suspected, but you still assess quickly. First, Assess responsiveness. Can the person wake up? Do they respond to voice? Do they respond to touch? Do they respond to painful stimulus? Second, assess breathing. Look, listen, and feel. What is the respiratory rate? Is breathing shallow? Are there pauses? Are there gurgling or snoring sounds? Third, assess pulse and circulation. If there is no pulse, start CPR according to basic life support guidelines and call for emergency help. Fourth, call for help. In a hospital, activate the appropriate emergency response, such as rapid response or code team depending on the patient's condition and facility policy. In the community, call emergency services. Fifth, support airway and breathing. This may include positioning, opening the airway, rescue breathing, bag valve mask ventilation, oxygen and suction if available and within scope and training. Sixth, give naloxone according to route available and facility policy or product directions. Seventh, continue monitoring. Naloxone is not a give-it-and-done medication. Pop test question. In suspected opioid overdose, what is the nurse's priority assessment? A. Hair texture. B. Breathing and responsiveness. C. Favorite food. D. Shoe size. The correct answer is B. Breathing and responsiveness are priority assessments in suspected opioid overdose. Now let's talk about nursing responsibilities after giving naloxone. After naloxone, reassess breathing. Is the respiratory rate improving? Is breathing deeper? Is oxygen saturation improving? Is the patient easier to arouse? Reassess airway. Is the patient vomiting? Are there secretions? Is suction needed? Reassess level of consciousness. Is the patient waking up? Are they confused, anxious, or agitated? Reassess vital signs. Monitor heart rate, blood pressure, respiratory rate, oxygen saturation, and pain level. Watch for recurrent respiratory depression. This is a big one. The patient may improve and then decline again. Be prepared to give additional naloxone if ordered or according to protocol. Continue to support breathing. If the patient does not respond to naloxone, think about possibilities. Maybe the overdose is not from opioids. Maybe there are multiple substances involved. Maybe the opioid dose is very high or long-acting. Maybe more naloxone is needed. Maybe the patient has another medical emergency, such as stroke, hypoglycemia, seizure, head injury, or cardiac arrest. This is why emergency evaluation matters. Do not assume every unresponsive patient is only opioid overdose, but if opioids are suspected and breathing is dangerously slow, naloxone can be life-saving. Pop test question. After naloxone is given, what should the nurse monitor for? A. Recurrent respiratory depression. B. Hair loss only. C. Increased height. D. Permanent cure of pain. The correct answer is A. Respiratory depression can return after naloxone wears off. Now let's talk about lab monitoring. Naloxone itself does not require a specific blood level. There is no routine naloxone level that nurses monitor, but labs may be important depending on the situation. In an overdose or altered mental status emergency, providers may order labs such as arterial blood gas or venous blood gas, glucose, electrolytes, kidney function, liver function, toxicology screening, acetaminophen level, salicylate level, and other tests depending on the clinical picture. Why glucose? Because hypoglycemia can also cause altered mental status. Why acetaminophen level? Because some opioid combination pills contain acetaminophen, such as oxycodone acetaminophen or hydrocodone acetaminophen. If someone took a large amount of combination opioid medication, they may also be at risk for acetaminophen toxicity and liver injury. Why blood gas? Because if breathing is poor, carbon dioxide may build up and oxygenation may be affected. In the hospital, continuous pulse oximetry may be used. Sometimes capnography may be used to monitor ventilation. Capnography measures exhaled carbon dioxide and can help identify hypoventilation. But remember, monitors do not replace nursing assessment. You still assess the patient's breathing, mental status, airway, and response. Pop test question. Does naloxone require routine monitoring of a naloxone blood level? A. Yes, every 4 hours. B. No, there is no routine naloxone blood level used in typical nursing care. C. Yes, before every meal. D. Yes, only with potassium. The correct answer is B. Naloxone does not require routine drug level monitoring, but the patient's respiratory status and overall condition must be monitored closely. Now let's discuss patient teaching. Patient teaching with naloxone is extremely important because naloxone is available outside the hospital. Teach patients and families that naloxone is used for suspected opioid overdose. Teach them the signs of overdose. These include very slow breathing, no breathing, inability to wake up, blue or gray lips, limp body, gurgling sounds, and extreme sleepiness. Teach them to call emergency services right away. Naloxone helps, but medical help is still needed. Teach them how to use the naloxone product they have. For nasal spray, place the tip into one nostril and press the plunger. Do not test the spray first. Most nasal spray devices contain one dose. After giving naloxone, place the person in the recovery position if they are breathing and you are trained to do so. The recovery position helps reduce aspiration risk if the person vomits. Stay with the person until help arrives if it is safe. If the person does not respond in a few minutes, or if they respond and then breathing slows again, give another dose if available and follow emergency instructions. Teach patients that naloxone may cause withdrawal symptoms. The person may wake up upset, confused, or physically uncomfortable. Still, naloxone is life-saving. Teach that naloxone does not work on non-opioid overdoses. For example, it does not reverse benzodiazepines, alcohol, cocaine, or methamphetamine. However, if opioids are mixed with other substances, naloxone may still help reverse the opioid part of the overdose. Teach patients taking prescribed opioids that having naloxone available is a safety measure, not a judgment. This is important because stigma can prevent people from carrying naloxone. You can say, "Naloxone is like a fire extinguisher. You hope you never need it, but it can save a life if an emergency happens." Pop test question. Which patient statement shows correct teaching? A. After I give naloxone, I should still call emergency services. B. Naloxone works for every kind of overdose. C. If the person wakes up, I can leave immediately. D. Naloxone causes an opioid high. The correct answer is A. Emergency services should still be called because overdose symptoms can return and further care may be needed. Now let's talk about who should have naloxone. Naloxone may be recommended for people at increased risk of opioid overdose. This can include people prescribed high-dose opioids, people taking opioids with benzodiazepines or other sedatives, people with a history of substance use disorder, people using illicit opioids, people recently released from incarceration, and people who live with or care for someone who uses opioids. It may also be helpful in homes where opioids are prescribed, especially if children or vulnerable adults are present, because accidental ingestion can be fatal. In many areas, naloxone can be obtained from pharmacies, community organizations, harm reduction programs, health departments, and clinics. The exact access rules vary by location, but in the United States, some naloxone nasal spray products are available over the counter. For nursing students, the key point is not just who deserves naloxone. The key point is access saves lives. Naloxone is a safety tool. It does not encourage overdose. It gives people a chance to survive and receive care. Now let's talk about what findings should be reported to the provider. In the hospital, report if naloxone was needed. That is a major clinical event. Report the reason it was given, the patient's respiratory rate, level of consciousness, oxygen saturation, vital signs, opioid medications recently received, response to naloxone, and whether additional doses were needed. Report recurrent sedation or recurrent respiratory depression. Report if the patient does not respond to naloxone. That may mean more treatment is needed or another cause is involved. Report severe agitation, violent behavior, chest pain, severe hypertension, severe vomiting, aspiration risk, or uncontrolled pain after naloxone. Report suspected acetaminophen overdose if the opioid involved was a combination medication like oxycodone-acetaminophen. Report if the patient may have taken multiple substances. For example, opioids plus benzodiazepines, alcohol, or other sedatives can increase danger. Report pregnancy if relevant, because opioid exposure and withdrawal considerations may affect care. Also report any safety concerns, such as access to unsecured opioids at home or repeated overdose risk. Pop test question. A patient receives naloxone and begins breathing better, but 20 minutes later becomes very sleepy again with slow respirations. What should the nurse do? A. Recognize possible recurrent opioid toxicity and take action. B. Ignore it because naloxone already worked once. C. Give the patient food only. D. Discharge the patient immediately. The correct answer is A. Naloxone can wear off before the opioid, so symptoms can return. Now let's walk through a hospital clinical scenario. You are caring for Mr. Johnson, a 64-year-old patient after surgery. He received IV hydromorphone for severe pain. 30 minutes later, you enter the room and notice he is very difficult to arouse. His respiratory rate is 7 breaths per minute. His oxygen saturation is 86%. His blood pressure is lower than before. What should you do? First, call for help. In a hospital, this may mean calling rapid response or following your facility's opioid emergency protocol. Second, stimulate the patient and assess airway and breathing. Third, provide oxygen and support ventilation if needed. Fourth, prepare to administer naloxone as ordered or per protocol. Fifth, continue monitoring closely after naloxone is given. If he wakes up and starts breathing better, that is good, but the situation is not over. You must continue to monitor because respiratory depression can return. You must also notify the provider and document the event. This is a classic nursing scenario: opioid medication, excessive sedation, low respiratory rate, naloxone, and reassessment. Now let's walk through a community scenario. You are at a community event and someone collapses in the bathroom. They are unresponsive. Their breathing is very slow and irregular. Their lips look bluish. Someone says they may have used opioids. What should happen? Call emergency services immediately. Check responsiveness and breathing. If trained and appropriate, start rescue breathing or CPR depending on pulse and breathing status. Give naloxone nasal spray if available. Stay with the person if safe. If there is no response in a few minutes, give another dose if available and follow emergency guidance. Place the person in the recovery position if they are breathing and you are trained to do so. Do not put them in a cold shower. Do not slap them repeatedly. Do not force them to drink coffee. Do not try to make them vomit. Those actions can be dangerous and delay life-saving care. The priority is emergency help, breathing support, and naloxone. Now let's talk about common myths. Myth number 1. Naloxone is dangerous if you are not sure it is an opioid overdose. Naloxone is considered safe and has no abuse potential. If opioids are not present, it usually has little effect. In an emergency with slow or absent breathing and suspected opioids, naloxone can save a life. Myth number 2. If naloxone works, the person is fine. False. The opioid can outlast naloxone, and symptoms can return. The person still needs monitoring and emergency care. Myth number 3. Naloxone encourages drug use. False. Naloxone is an emergency rescue medication. It does not cause a high. It gives someone a chance to survive. Myth number 4. Naloxone only works if injected. False. Naloxone can be given intranasally with nasal spray, and that is commonly used in community settings. Myth number 5. One dose always works. False. Some overdoses require more than one dose, especially with potent or long-acting opioids. Now let's review the most important nursing points. Naloxone is an opioid antagonist. It blocks opioid receptors. It is used for known or suspected opioid overdose. The priority sign of opioid overdose is respiratory depression. Look for slow breathing, shallow breathing, no breathing, extreme sleepiness, inability to wake up, blue lips, limp body, gurgling sounds, and pinpoint pupils. But do not wait for every sign. Breathing is the priority. Naloxone can be given intranasally, IM, subcutaneously, or IV, depending on the setting and product. Naloxone can work quickly, but it may wear off before the opioid does. Repeated doses may be needed. The patient needs continued monitoring and emergency care. Naloxone can cause sudden withdrawal in opioid-dependent patients. Withdrawal can include agitation, sweating, nausea, vomiting, diarrhea, body aches, fast heart rate, and increased blood pressure. Naloxone does not treat non-opioid overdoses, but it may help if opioids are part of a mixed overdose. Nursing responsibilities include assessing responsiveness, breathing, pulse, oxygenation, airway, and level of consciousness. After naloxone, monitor respiratory status, sedation level, vital signs, pain, withdrawal symptoms, vomiting, aspiration risk, and recurrent respiratory depression. Teach patients and families how to recognize overdose, how to give naloxone, to call emergency services, and to stay with the person if safe. Memory tip: Narcan knocks opioids off, but monitoring must not stop. Now let's finish with 5 true or false review questions. Question 1. True or false? Naloxone is an opioid antagonist. The correct answer is true. Rationale: naloxone blocks opioid receptors and reverses opioid effects, especially respiratory depression during overdose. Question 2. True or false? Naloxone replaces the need for emergency medical care. The correct answer is false. Rationale: naloxone is emergency treatment, but the person still needs emergency evaluation and monitoring because opioid effects can return after naloxone wears off. Question 3. True or false? Naloxone can cause withdrawal symptoms in a person who is physically dependent on opioids. The correct answer is true. Rationale: naloxone can suddenly block opioid effects, which may trigger withdrawal symptoms such as agitation, sweating, nausea, vomiting, diarrhea, body aches, fast heart rate, and increased blood pressure. Question 4. True or false? The main priority in suspected opioid overdose is improving breathing. The correct answer is true. Rationale: opioid overdose can slow or stop breathing. Naloxone is given to reverse opioid-induced respiratory depression, and airway and breathing support are priorities. Question 5. True or false? Naloxone works for every type of overdose, including alcohol-only overdose and benzodiazepine-only overdose. The correct answer is false. Rationale: naloxone reverses opioid effects. It does not reverse alcohol, benzodiazepines, stimulants, or other non-opioid substances, although it may help if opioids are involved in a mixed overdose. And that is your beginner-friendly nursing pharmacology review of naloxone, also known as Narcan. Remember, naloxone is an opioid antagonist. It knocks opioids off the receptor. It can reverse life-threatening respiratory depression, but it is not the end of care. After naloxone, the patient still needs monitoring, emergency evaluation, and support because symptoms can return. As a nurse, always think airway, breathing, responsiveness, naloxone, reassessment, and safety. Thank you for watching, and I'll see you in the next nursing pharmacology lesson.